Good evening, everyone. Thank you so much for joining us. My name's Jamie Strauss. I'm the Chief Clinical Officer at Viz AI, and I am happy to have Dr. Ronald Wharton join us. He's the director of the HCM program at North Shore University Hospital. We're going to be talking today about advancing the care of HCM with AI. For some notes, there's a Q&A session. So during the webinar, please feel free to drop your questions in there and we'll get to them at the end of this session. So Dr. Wharton, going to kick it over to you.
Thank you so much. And it's a pleasure to be here. I assume I'm audible? Yes? Oh,
You are.
okay. So it's an exciting time to be treating hypertrophic cardiomyopathy because the therapeutics have really blossomed over the past couple of years and will continue to do so in ways that I don't think anyone could have ever anticipated until very, very recently. Hypertrophic cardiomyopathy is the #1 cause of sudden cardiac death in young people. It is something that we can now take care of in such a way that if we do it right, people can live a lifespan that's close to normal. And it is extremely underdiagnosed. The current estimates are that hypertrophic cardiomyopathy in all forms might have a prevalence of as much as 1 in 200, or approximately 0.5% of the population. And yet, if you look at all of the billing that's done from insurance companies nationally and compare it to what the prevalence should be based on how the American population, we can guess that somewhere between 80 and 85% of patients with hypertrophic cardiomyopathy remain undiagnosed, which is really quite extraordinary. Now, why is that? Well, don't forget, the symptoms of hypertrophic cardiomyopathy are not unique to hypertrophic cardiomyopathy. What does hypertrophic cardiomyopathy do? Some people just feel fatigue. Some people feel lightheaded. Some people feel short of breath when they exert themselves. Some people feel chest pain. Some people have palpitations. These are not symptoms that are in any way unique to hypertrophic cardiomyopathy and can be attributed to a lot of other things, from hypertension, obesity, stress, valvular heart disease, and the physical exam can often be unrevealing. Not everybody with hypertrophic cardiomyopathy has a murmur. Not everybody with hypertrophic cardiomyopathy who has a murmur necessarily has the murmur of a sufficient intensity when patients are examined. The murmur is a moving target. Sometimes it's louder, sometimes it's shorter, softer, depending on physiologic maneuvers or level of activity. So this can easily masquerade as other conditions or go undiagnosed. And not every patient with hypertrophic cardiomyopathy has an ECG that shouts out at you, I have hypertrophic cardiomyopathy. Electrocardiographic diagnosis can be very, very difficult to make with the human eye. According to data that has been published from journals and from surveys from the Hypertrophic Cardiomyopathy Association of America, the average number of diagnoses that patients get before it's gotten right is 4. It's typically at least 5 visits to a clinician before the diagnosis can be made, and the diagnosis can be delayed on an average for as long as 5 years. I can tell you in my own personal experience that the first patient treated in the United States with mavacamten, which happened to be my patient, had been misdiagnosed with quote-unquote aortic stenosis plus mitral valve prolapse for over 10 years, and only came to my attention because she was referred to my hospital's clinic for consideration of an aortic valve replacement via TAVR. And it was only then, when somebody else looked at the echocardiogram other than the referring physician, that the diagnosis was made. So this is an extremely undiagnosed clinical entity. It does lie under the radar for extended periods of time and leads to unnecessary suffering, especially nowadays when we can really treat these patients in ways we never thought we could before. Just to show you what this looks like, I am an echo person. This is the typical splay of turbulence. Now, not everybody with hypertrophic obstructive cardiomyopathy has mitral regurgitation, but many patients do. And this typical V-shaped turbulence, where you have subaortic turbulence over here. Partial of this is going into the aorta. This is the LVOT obstruction, and this patient also happens to have a lot of concomitant mitral regurgitation, which again is not necessary but often common. This is what it looks like on echo, and when you see this as an echocardiographer, you know what it is. You don't have to look at anything else. for years, and hypertrophic cardiomyopathy in the United States was first described in the American Journal of Medicine in the early 1960s by Eugene Braunwald and the National Institutes of Health. And for years, we have been using medications that were repurposed from other conditions, typically beta blockers, disopyramide, which is marketed under the trade name Norpace, and the non-dihydropyridine calcium channel blockers, specifically verapamil and diltiazem. Now, there was no literature on using these. It just sort of made sense because they had physiologic properties that one would think would be favorable. Beta blockers decrease inotropy, which helps patients with obstructive HCM. They also decrease heart rate. When you decrease the heart rate, you increase diastolic filling time. That allows the ventricle to get bigger, and that's a favorable thing to do when you have obstructive hypertrophic cardiomyopathy. Norpace, which is a class 1A antiarrhythmic, is a very, very potent negative inotrope, and therefore has very, very good ability to decrease LVOT obstruction. However, beta blockers and Norpace have significant side effects, as do calcium channel blockers, verapamil and diltiazem. Verapamil and diltiazem, even though they are negative inotropes, they do have some vasodilatory effects which counteract what you want to do in patients with obstructive hypertrophic cardiomyopathy. Beta blockers lead to fatigue. They lead to depression, and men don't like them for obvious reasons. Norpace, disopyramide, has a lot of anticholinergic effects. In fact, I usually don't prescribe Norpace unless a patient is on a beta blocker first, because the anticholinergic effects can accelerate conduction through the AV node. But the anticholinergic effects of Norpace can be profound: constipation, dry mouth, urinary retention, blurred vision. Sometimes I've had to prescribe patients Mestinon to treat the side effects of the Norpace. It's perhaps the only time in my clinical practice where I've had to prescribe one medication to treat the side effects of another medication. And calcium channel blockers, again, constipation is very common with verapamil and diltiazem, peripheral edema, which is especially worse at the end of the day, fatigue and headaches as well. And you could frequently throw the entire pharmacy to these patients and still not have an optimal result. Still patients with significant left ventricular outflow tract obstruction, after which the only traditional alternatives were what are now referred to as the septal reduction therapies, either surgical septal myomectomy or an alcohol septal ablation. And of course, those procedures have their own issues too. Septal myectomy, there's a potential for a ventricular septal defect. It should really only be performed by a surgeon who does a lot of them. Alcohol septal ablation, you never know exactly how much muscle you're going to take off. It's blind until you actually look at the coronary anatomy. You never really know if you have even a good septal perforator. There's a very high likelihood you're going to end up with a permanent pacemaker. And compared to septal myomectomy, if you look at the literature, it's somewhere around the vicinity of 5 times more likely that you're going to need a repeat procedure compared to that for septal myomectomy, because the first procedure just didn't work as well as it should. Septal myomectomy is not for septums that are too thin or too thick. So if the septum is less than 15 millimeters, it's probably not a good idea. And if it's more than 25 millimeters, it's probably not going to work. So what's new and exciting? It was, I believe, last April 29th of 2022, when the first cardiac myosin inhibitor got approved by the FDA for the treatment specifically of obstructive hypertrophic cardiomyopathy. This is the first time that we're using a drug that was actually targeted for this condition. Remember, all of the other agents we mentioned were drugs that were repurposed from other conditions to treat HCM. This is the first time we actually have a directed therapy. Mavacamten has been studied in 2 major trials, and of course there's been a lot of follow-up on those trials subsequently. I mentioned the Explorer HCM trial here because this is the trial that was published in Lancet in August of 2020 that actually got the drug its FDA approval. And just to cut to the chase, what I'm showing you here are 6 bar graphs that compare the placebo and treatment arms. In total, there were about 240 patients in this trial. And you can see here that we have the resting LVOT gradients, the exercise, the Valsalva LVOT gradients, the exercise LVOT gradients. We have levels of, I'm sorry, so this is actually the exercise one over here on top. Let me show you that. And this is over the course of 30 weeks. This is the resting LVOT gradient difference. This is the Valsalva LVOT gradients. Okay, these two graphs here are changes in BNP and cardiac troponin I. These are markers of myocardial wall stress. So we have serologic data as well as LVOT gradient data. As an aside, we also have data in the Kansas City cardiomyopathy questionnaire, which showed, I think, something in the vicinity of a 16-point improvement in symptoms. Compare that to what you got with Entresto, which I think was about 1 point. So dramatic differences in all of these endpoints here. The only things that were superimposable is right here. This is ejection fraction. Now, you may ask why that is, and that's probably because what you're losing in inotropy, you're gaining in afterload reduction. Don't forget, ejection fraction is an afterload dependent phenomenon. When you reduce the afterload, the EF goes up. And you may be taking some of the inotropy away. Don't forget, these patients usually have very, very hyperdynamic hearts to start with, so you've got a lot of room to play with. But when you decrease the inotropy, you're also decreasing the afterload because you're decreasing the LVOT obstruction. So the ejection fraction in this trial, as was also true in the subsequent trial, the Valor HCM trial, did not significantly change. And I'm just going to show you this one slide for the sake of time constraints from Valor HCM. Valor HCM looked at a higher risk group. These were patients, all of whom were eligible for septal reduction therapy. That means that they had an LVOT gradient of at least 50 millimeters of mercury, and that could either be at rest or with provocation. And initially, in this trial of 108 patients, I believe, you can see here that patients who were treated with mavacamten had a dramatic decrease in the need for septal reduction therapy. And after 16 weeks, patients crossed over from the placebo arm to the active treatment arm. And you can see here in the, as opposed to the placebo crossover group and the original mavacamten group, both had dramatic changes in New York Heart Association class, at least one or sometimes even a change of 2 in class. So both trials, very, very positive. And I can tell you that in the Valor trial, the curves in this trial were very similar to the trials that I showed you in the Explorer HCM trial. So these were the same. So in any way, a little bit about my experience using cardiac myosin inhibition in my practice. This is one of the first patients I treated, and you can see on the left the baseline echocardiogram from May of 2022. And this is an unprovoked LVOT gradient of over 100 millimeters of mercury. Contrast that with what happened a few months later after she's treated with mavacamten. This is the same view now. And look at how this is now a provoked gradient of less than 20. We went from unprovoked of over 100 to less than 20 provoked with a Valsalva gradient. And you'll notice that the LV looks still robust. The ejection fraction is not appreciably changed at all. I've personally treated about 70 patients now with this agent, and I have not made any enemies. I have taken some patients from class 3 heart failure to spinning class. So it's really an exciting time to be playing with these medications. All the more reason that we have to find patients who have this condition, because now we can really help them a lot, and we can do it without a scalpel, and we can do it without blind alcohol-related procedures. We can really do this in a very, very safe way. And if a patient does have an untoward effect, which is very, very rare, the drug has no permanent side effects. It gets metabolized. But remember, we can't treat patients if we can't find them, and we need to be able to find them. Because again, the insurance data, when compared to the American population, suggests that at least 80% of the patients who are out there with HCM don't know they have it. And again, there are 3 reasons patients get referred from primary care, typically to cardiology. It's either because of symptoms, or because of a physical exam, or because of an EKG. The symptoms can sometimes be very, very subtle. The physical exam is not always revealing. And the electrocardiogram to the human eye doesn't necessarily tell you everything that it needs to tell you, which is why we have new technologies. And with that, I'd like to turn the talk over to Ms. Strauss.
Thanks, Ron. That's wonderful. I'm going to give an overview of Viz, but before we get there, can you talk a little bit about how you do think that ECGs may be used more effectively to identify HCM patients, especially in community?
Sure. I think the best place to use the technologies that we now have is in primary care. Cardiologists will typically tease out a reason to get an echocardiogram if a patient has any symptoms that suggest that it might be something cardiac, whether it's HCM or valvular heart disease, or just even a diastolic abnormality leading to symptoms such as shortness of breath, exertional dyspnea, and the like. But it's really getting the patients into the cardiology office, because don't forget, if a patient has a symptom for the first time, they're going to go to primary care. They're not going to be going to their cardiologist. That's the point of entry. And even for cardiologists, making the diagnosis on ECG that a specific diagnosis on ECG can be very challenging. Of course, that's why we have echo. But for primary care, where you have to primary care doctors and allied providers, nurse practitioners, and the like have a lot to think about. And HCM is not necessarily on the radar because it is just something that is not thought about as much. But everybody in primary care can get an EKG. And if the EKG can tip someone off saying maybe this patient should get a cardiology referral, okay? In the world of risk reward, there is absolutely no risk, but there's a potential for a lot of reward. So there's every reason, just as computers are now being used to identify radiologic abnormalities, such as improve the detection of breast cancer or findings on a head CT scan, it can be used for electrocardiogram too, and we should embrace that technology.
Thank you. Appreciate your insights. And we have some questions already in the chat for you, so I'll come back to you as soon as I go through. So who is Viz? For those of you on the call that don't know, so Viz is an AI company, and our mission is to improve access to life-saving therapies for patients. We as a company started in the neuroscience space in stroke. And since then, we've grown to 12 cleared FDA submissions. 2 of them have been de novo. Our stroke platform, our stroke AI was the first ever FDA de novo. And our HCM also received de novo approval from FDA last month. We also have an additional 2 in submission. We really span across various disease states that started in neuro, across radiology as a whole, cardiovascular, and trauma. We have a lot of users, 35,000 users across about 1,500 health systems and some of the largest health systems and IDNs in the country. And we've really focused on clinical evidence and clinical rigor to ensure that we're not only improving the experience for our users, whether that's a clinician and a nurse, a scheduler, whoever it may be, but we're actually impacting patients. So we've really committed to creating clinical evidence. We're published in over 100+ journals, and this is some of our proven outcomes that we've seen across various disease states. We also take that clinical evidence and really work to ensure we were able to receive the first ever NTAP reimbursement for AI. So how do we work? So we really work in the cloud to ingest all types of healthcare data, and that can be imaging modalities, EMR, echo, ECGs, as we talked about. And what happens is we ingest that data, it gets analyzed by the algorithms in the cloud, and we work really closely with the site to understand the clinical workflow and who needs to be aware and notified of these patients, and how do they need to be notified and aware of these patients, no matter where they are in the health system and no matter what time of day it is. And by doing so and creating that trigger of action, instead of just, putting a finding back into the EHR, we've really been able to enable therapy that has driven these improved patient outcomes. And we're going to talk about our early experience in HCM and our sites, and you're really going to be able to see how we've been able to shorten diagnosis time frame from our mechanism and our system of action. So the development of the algorithm, we really wanted to make sure we had a robust data set with a lot of diversity through our demographics. We know that minority populations are often most impacted by HCM. So we worked and had a total of over 830,000 ECGs. This was a global data set. We really looked at training the model based on non-obstructive, obstructive, but also mimics that Dr. Wharton talked a little bit about. These came in global sources, and then we did the validation and the ground truthing on with echocardiography or cardiac MRIs, what was available for that data set. And you can see our overall performance, sensitivity 68.4%, specificity is at 99%, and PPV is at 13.7. So as we've also evolved the algorithm and implemented in more sites, we've seen improved PPV across those sites. So what does the software do, and what does it look like, and how do you use it in your day-to-day practice? So really what we do is we ingest all of those ECGs that are flowing through the healthcare system, and we analyze them. And from that, there is a curated list of patients that get flagged for suspected HCM. We've seen in our early sites, sometimes, it's seen by the naked eye that there's changes on the ECG, but most of the time, to most providers, it looks like a normal ECG, and even to the most well-trained providers in HCM, the ECGs look normal. We then curate a summary of that patient with EHR information, and we work with this site to identify what that information is, and we pull in specific data points. Most often it's past medical history, who's their PCP, do they have an existing cardiologist, what is their medical therapy, what is their past procedural history. And then we're also ingesting in as that patient moves through their care journey, or if they've had a previous echo, we pull that in. And we run AI on that to really give you a quick summary on your LVOT and some of your other critical measurements for HCM. We also have the viewers where you're able to see them directly in the app. And Dr. Wharton can talk a little bit about, he's seen it and knows how those viewers look. And they really are, you are able to see the findings on them. But from there, you're then able to truly interact with your care team in your clinic, whether it's, and we've seen a diversity of users, whether it's your clinic scheduler, your MA, your nurse, your APP, pharmacy is heavily involved in a number of these sites with these patients. And you're able to move that patient through their journey pretty quickly and get them to the appropriate scheduler to follow them. And as you see them through the clinic and through their journey, and when they have their cardiac MRI done, everything is funneled back through to you. So you have an easy way to track your patients. So I've sat with a number of schedulers and MAs and nurses who have these spreadsheets, and now we have a way to automate where the patient is in their workup and journey. So the workflow, we've talked about this a little bit through that, is it's really starting with that 12 lead ECG, and we do work to implement, especially out into the community, but connecting to the experts at the different center levels to help make sure that patients don't get missed or don't get misdiagnosed. And we work to identify what that looks like. So with Dr. Wharton at Northwell, it's really like bringing in the community cardiologist, getting the flow from the PCPs, and then the ability for them to send to him for those that really need that elevated level of care. And then you can see all of their data through their whole history. We do ingest PHI, so you are able to see as that patient progresses through the course of their disease over years. So far, we've implemented early under research IRB in 5 workflow pilot sites. And we're at about 6 months standpoint in some of those sites, and a little bit more in others, that we ingested 125,000 ECGs. And from that, we found 131 patients confirmed with HCM, and another 120 across the sites are in follow-up. And we've had some really interesting cases. And one of the cases I would like to share with you is, this is a 45-year-old male. He came into the cardiology office, had history of hypertension, had some complaints of lightheadedness and palpitations. So again, to Dr. Wharton's point, this patient made it to the cardiologist because they were symptomatic. Patient had previous ECGs where HCM was not a rule-out diagnosis or was not identified. And we were able to move this patient pretty rapidly through their diagnosis pathway. So you saw earlier about 5 years to diagnosis. This patient was able to get to diagnosis in 2 months. and really track that patient through. So they were able to get their monitor, their TTE, they were able to get their cardiac MRI and all of this. And you can actually see the real chat here of them, coordinating the care for this patient. And then this patient was then risk stratified to therapy. So I'm going to stop there. I'm going to open it up to the audience for any Q&As. I think we do have some questions in here. I know you answered some of them, Ron, but would love for you to give a little bit more dialogue on it. So
Sure.
do you foresee that more cardiologists who are non-HCM specialists being able to manage these patients with arrival of new therapies?
The answer is yes, depending on their level of interest, their degree of verve, and perhaps their degree of masochism. And I say that partially jokingly. The new molecules, the way they've been rolled out by the FDA, can be very labor intensive. There is a REMS program for mavacamten. I believe there will likely be a REMS program if and when aficamten gets approved. It's a lot of echoes. It's a lot of hassles with insurance companies and with specialty pharmacies. Learning how to play with these medications and the interactions with other drugs, and also the effects that they have that you might anticipate but nobody really talks about, can make it a little labor intensive. My own experience has been, for instance, that you will sometimes bring out hypertension, and if patients have hypertension, you will sometimes exacerbate it. Now, if you think about it, it sort of makes sense. You're opening the floodgates, right? You have a lot of blood trapped in the heart, and all of a sudden the flux through the LVOT is reduced and patients' blood pressures go up. When I first started using this drug, I had one patient whose LVOT obstruction was so profound that she never had a blood pressure systolic of more than 90. And when she came for her first echo, her blood pressure was 110. She said to me, my blood pressure has been going up. And I knew even before the echo that the drug had to be working. So there are a lot of caveats about playing with these drugs. And a lot of things that I personally have learned about the mitral valve in patients who have HCM, because you still find a lot of mitral you actually frequently unmask a lot of mitral pathology when you relieve the SAM. That's a separate discussion. Suffice it to say that you can do it from the office if you are dedicated enough, and it does require a lot of time. It does require a lot of stick-to-itiveness, but I can also tell you that it's extraordinarily gratifying, because you're taking patients and you're giving them their life back. And it's really quite extraordinary that you have one pill once a day with minimal side effects that can replace this whole armamentarium of drugs that never worked that well and had lots of side effects. So that's my short answer. If you'd like a longer diatribe about it, contact me afterwards. I'll be happy to discuss it.
Thank you. I have a question here I'm going to answer. Is this approved by FDA and available to all doctors in and outside of HCM centers of excellence? So this is approved by the FDA. We got de novo approval last month, and this is open to all centers. So if you are interested in discussing, there's the link here on the screen, and we're happy to set up a call with you, as well as do a demo and also learn about your program. Is the ECG the current gold standard for HCM diagnosis? If not, how receptive are insurance companies to covering and reimbursing for the use of the device and therapies as a result of the device's use? So do you want to talk a little bit about the current gold standard of HCM diagnosis?
Well, the diagnosis is an echo. Let's be clear about that. When patients first have symptoms, they're not necessarily going to go to a doctor who has an echo machine in their office. They're going to go to primary care first. HCM, the care of HCM patients obviously involves a lot of stuff. It requires cardiac MRI. Sometimes it involves interventional cardiology. It involves genetics. It involves a lot of electrophysiologists. But it's first and foremost a diagnosis that's made by echo and a diagnosis that is followed by echo. And that has to be very, very clear. Which, the REMS program doesn't call for an MRI every 4 weeks. It calls for an echo every 4 weeks, and then specifically thereafter. It's an echo disease, which is why I think echo people are the most qualified to take HCM by the reins in the modern era that we have of targeted molecules.
Yeah, and I can add on from the receptive of the insurance companies. So at least from our standpoint, right, our technology is a triage device. So it is not a diagnostic device. It is not meant to improve or replace the standard of care and the physician evaluation of the patient. So what we're really doing is evaluating and saying, hey, this patient looks like there's a high probability that there's something here that looks like HCM. The goal is then for the physicians to kind of screen those patients, do their assessments, collect the family history, and follow their standard workup that they would do as normal if this patient presented with symptoms. Dr. Wharton, another question for you. Are referrals coming in from community sites? If so, does that indicate the primary care can effectively flag potential HCM with this solution?
No, I don't see it that way. HCM centers are incredibly busy, and actually it's great that we're very, very busy. I'm not complaining at all, but we really need to see patients that are referred because the diagnosis has already been made. If we start seeing patients, everybody in whom, the diagnosis is a consideration, we'll never be able to get home. So no, I foresee this as a tool to help steer patients to get to a cardiologist, because the algorithm may identify HCM, and if it doesn't, it may identify something else that the cardiologist may want to see also, whether it's hypertensive heart disease or aortic stenosis or amyloid or whatever. I see this as a tool to perhaps alert primary care that the patient may need to be referred to a subspecialist, but I don't see nor do I want particularly primary care referring everybody who might have HCM to an HCM center because we'll be flooded. We'll never get out. It's like sending everybody who might have coronary artery disease to an interventional cardiologist. It's a little premature.
I think we'll take one last question because we are at time. And again, we're happy to answer any additional questions. You can click on the link here. The question around PPV of 13% being very low. Dr. Wharton, do you want to talk a little bit about PPV and the number of ECGs, or I can take this as well from...
You can take that one.
Yeah, so when you actually think about the PPV of 13%, because you're ingesting so much data and there's so much data and based on the prevalence of patients, it's actually a pretty good PPV for what we think the prevalence of disease is. When we originally started working on the training, it was even lower, but we've worked to really increase the PPV of the algorithm. So I'm happy to provide you more information around that. If you want to reach out, we can kind of review the explainability model and all of that of the algorithm. And I think with that, we're at time. So I would like to thank everybody for joining us. We hope to talk to some of you. So if you have additional questions, please feel free to reach out to us. Dr. Wharton, always a pleasure. Thank you so much for joining us. Appreciate it.
Thank you very much.